Good evening, everybody. Welcome to an ANZASM webinar about morbidity and mortality meetings. I'm Philip Mackay. I'm the Clinical Director of VASM, and we've got a really top-notch group of speakers tonight, and we'll hopefully come up with some sensible ideas and some controversial things. What I need to do initially is go through the welcome to country. RACS acknowledges the Aboriginal and Torres Strait Islander people as the traditional owners of the land that we're all on today, and extend our respect to elders past and present. I would like to acknowledge the Aboriginal and Torres Strait Island people as the traditional owners of country throughout Australia, and respects their continuing connection to culture, land, waterways, community, and family. These are some of the papers that we'll be referring to today. And if you're interested in these, the first one on the left is from RACS. The middle one is produced by Safer Care Victoria last year. And the one on the right is bang up to date. That's a leader from last week's Medical Journal of Australia, where my colleague James Aiken has talked about clinical quality registries as well as morbidity and mortality meetings. And if you want to have any of these, there'll be some links put in the chat as we're going along, and also some links to them with the eventual thing we have put on the web when this is all over and done with. Moving on, the first speaker tonight is probably quite well known to most of the surgeons, and that's Guy Madden, who's the R.P. Jepson Professor of Surgery at the University of Adelaide. Probably more importantly, he's also my boss at ANZASM, so we have to be very nice to him. He's the Director of Research at the Basil Herzl Institute for Translational Health Research at the Queen Elizabeth Hospital, and Director of Surgical Research and Evaluation at the Royal Australian College of Surgeons.
Look, thank you very much, and thanks for the opportunity to talk to you about the RACS M&M guidelines. Some years ago, RACS decided, lots spoken about M&Ms, but not a lot of guidance was out there in what they should look like and how they should be run. So we sort of thought we should develop the sort of approach that would be typical of an M&M meeting. We have the terms of reference, we have a structured format, we have structured case identification, structured case presentation format, agenda would be distributed. Multidisciplinary involvement would be present, so you'd have oncologists or physiotherapists or radiologists or pathologists or whatever was appropriate for the meeting. You would have this meeting regularly. It would be held first Monday of every month or every quarter or whatever was appropriate for the volume of work you wanted to assess and look at. You needed to have these coordinated. You needed software to support it. Ideally anyway, the ideas of ring binders probably has moved on for most organizations, and we wanted to have you want to have an environment where there's self-reporting of cases or errors to the group. So this was thought by the review group to be the types of things that needed to be incorporated into an M&M meeting, and I would suggest that all of us have been involved in M&M meetings, but and all have had elements of these issues. I'm not sure we've always set them up with a very strict discipline. If you're conducting an M&M, you need to, I think, to make these work and to make them work long term, it's all about focusing on the system that you're working in and not trying to pick off individuals. There will, of course, be individuals who have made a mistake or made an error of judgment or not given the leadership they should have given, and that can come out. But then the system should have picked that up, and that's not always occurring, and the system needs to be addressed. We do need to review the near misses and understand that they are a factor that needs to be taken into account. We need to have moderation of these meetings so that it's not just a mute chairman sitting there. You need to have active engagement. And so these meetings need to be chaired well. It's not about having some old bald man sitting there telling you what needs to be done, or about actually engaging the issues and making sure they're being dealt with. And you need to have a blame-free environment. So what do you need to get out of these M&Ms? Well, you need recommendations for individual and system improvement. So you need to be able to identify the changes that are required in the system. And obviously you need to come up with practical changes. If you don't have an ICU, there's not much point in asking for one. It's more about working out how you would transfer earlier so an ICU wasn't required, and so on. You need to look at the timeline. So some of these changes should be made within the next week. Some are obviously going to take longer. And if an M&M is well conducted, you'll be able to encapsulate that some of these changes are really urgent and need to be dealt with as a matter of urgency. Some are things that we need to be aiming for, and that in the next, within 3 months, we will have put these into place, or whatever it is. I think the problem is if you walk out of the room with no one taking the responsibility to pick up those issues, it's not going to work. So whoever's identified the problem, or whoever was responsible for the problem, or someone who's completely supportive of it but not necessarily directly engaged, it's their task to lead the implementation. Otherwise, it's a talk fest and nothing changes. And finally, last slide of this, you need to have detailed records. You need to be able to have a proper minute that records that Dr. X will be dealing with the problems of pathology results not being brought to the attention of the team on a weekly basis, or whatever it is, and it becomes their task. Obviously, they don't have to do it. They just need to be responsible for ensuring it occurs. We also looked at, and a lot of this was all based on a systematic review, we looked at ineffective M&M meetings, and poor attendance is probably the kiss of death for M&M. Unless you get all of the relevant people in the room at the time, these meetings are never going to succeed. And obviously, people have holidays, people have sick leave, but you cannot say, I'm not coming to the M&Ms because that's my operating list at hospital down the street. You have to set these up so that all of the team can be present to participate. And I know it's not easy, but I think if you're not going to do that, you may as well not have them. You do need, a lack of training and preparation for these meetings is also the kiss of death, because nobody wants to waste their time coming to something that hasn't been properly prepared. I think there is, and I don't think it's very widespread, we certainly didn't identify it in the systematic review, there is a bit of a negative perception of M&Ms, that they perhaps are set up to beat people up or to make people behave in ways they don't want to, but that's clearly obviously not the case. And if they're well run, it's absolutely not. There are always logistical problems in setting up these meetings, and they just need to be faced and dealt with. And the chaotic heterogeneity in the structure and presentation and discussion doesn't lead to a very constructive approach. And what was clear from the review was that we needed to have a very systematic, straightforward way of doing things. This was the review we did, and this is some years old now, but it looked at morbidity and mortality meetings, and we thought on review that maybe this could be broken into gold, silver and bronze, because not everybody has the sort of infrastructure to deliver a gold class M&M, but we ought to at least have an adequate M&M, such as a bronze version. When we looked at this, you can see across there we have bronze, silver and gold, and I think you can grasp the sort of the tenor we were trying to get here. And as you can see, everyone should have a structured case identification, consistent structured meeting format, regular meeting occurrence and duration, and written terms of reference. And then if you're lucky enough to have the resources, prior dissemination of agenda in cases. Conduct is basically the same for all three, with consistent cases, a blame-free environment, and that's the chairman's job. They must not turn this into a blaming session. Systems focus, and something that is really nice to have, but I accept is difficult to set up and does require quite a lot of work, is a review of close calls as well as the formal M&M. So if we look at the outcomes, we absolutely need to assign a timeline for recommendations. I've talked about that already. We need to get the individuals to carry out those recommendations, and without that, I think it's difficult, but you can't always do that. Good records, an audit of the M&M meeting procedures, a follow-up of the implementation recommendations, and ensuring that individual system improvements are made for each case. And again, it's difficult if you don't have a bit of infrastructure behind you, but obviously, as much as possible, we should be aiming for that. To conclude, these are not judging activities. This is not about the old man setting himself up to tell everyone what fools they are. It's more about a team approach. And we've had this experience in South Australia just recently. We've had a team that has disappointed us, not performed as we expected. There are a number of reasons for this. Unfortunately, on Friday night, that will all be reversed, but it will be because of the team looking at the issues and bringing them forward. As has already been shown, we do have this information available on the website of the college. There is the publication in the ANZ Journal, and I'm told by my research assistant that is a QR code which you can lock onto, and it will take you to the College of Surgeons Research Audit and Academic Surgery site. So on that note, I hope that's useful. I think the information's there, and I'd urge you to think about it. Thank you.
Thanks very much, Guy. Probably time for one or two questions. What level of privacy and restriction of access to M&M meetings in each hospital is required, and who should have access to the deliberations of the meetings?
Yeah, that's an extremely good question. Strictly speaking, it should be a defined audience that is there. You know, the consultants, the pathologists, all those people I mentioned. The difficulty is, I think that M&M meetings are there for the whole team, and I also think that having medical students there is an enormous advantage for them. They can begin to learn how professional people behave. And so in South Australia, we used to have these protected. We no longer have them protected. And I am unaware of any case in Australia where the discussions of an M&M have ever appeared in litigious situations. One has to bear in mind, of course, lawyers can always access the case notes and all the information that inform the M&M. And I think when you're making minutes, they've got to be done in a way which constructively reflects on them. I think the risks of litigation are far less than at the moment we should be concerned about, and the benefits outweigh those risks.
Our next speaker, we're delighted to have Audrey here from WA, and she's the Executive Director of Patient Safety and Clinical Quality Directorate in the Western Australian Department of Health. Also Medical Administrator with local and international clinical research and commercial expertise. And she's previously worked at Sir Charles Gardner Hospital and in academic centres of Vanderbilt and Oxford universities, and within the commercial sector at Roche UK as the Associate Medical Director at the General Electric Healthcare's Northern European operations. So very well travelled. So delighted to have you here, Audrey, and I shall pass everything over to you.
Thank you. So thank you for the invitation. It's my pleasure to talk about surgical M&Ms and just to give you a glimpse into what departments of health might expect. So only because I know how excited surgeons get about accreditation, I thought I'd start with a slide about the accreditation standards, and specifically Action 1.28, which relates to the health service organization's responsibilities in terms of looking at variation in practice against what you'd expect and having systems in place to support that. And that could be a number of different things, including M&Ms. I think key there is around providing feedback to clinicians in terms of their practice, support to clinicians in taking part in clinical reviews. I noticed that in one of the chats, there was a comment about lack of secretariat support and some of that infrastructure that helps people find time to do these sorts of reviews, and using information to inform improvements in safety and quality systems. And then I think key here is about identifying and escalating the risks up instead of keeping them just within that clinical department. So I thought before I talk about the surgeon's role, it'd be useful to talk about what the hospital's responsibilities are from where I sit. So I think the hospital's role here is to provide the enabling environment. So our staff supported to participate in preferably external data collections, registries, audits, and reports that cover the specific areas of interest to that clinical department. Does the organization or hospital have an M&M policy or some sort of guidance that sets out the expectations? If you find something untoward, does your organization have an escalation process that you can use? Does it have a system for identifying any clinical risks? Does it have a risk register where you can escalate things, if not to management and the board, at least know what actions need to happen? Most of the things you will find in an M&M can probably be dealt with, through the recommendations that Guy's talked about, but occasionally you will find things that where you will need your hospital's corporate governance, HR functions, etc., to support you in taking the necessary actions. And I guess the question is, how well does that occur? Because that becomes a feedback loop, usefully or not. And I guess the other bit is, does the organization have a schedule of data or reports that's provided to your board and to clinicians? And does it ensure that they're comprehensive, relevant, cover the actions required? So that's what I think your hospital's responsibilities are. In terms of the surgeon's responsibilities, do you participate in clinical quality registries, audits, and other reports that are relevant to the work of your department? Within the department, is there regular review of clinical practice data by clinicians, not just by hospital managers or analysts? Does this review identify variation from either best practice or variation in patient outcomes? And when you do see that variation, is there a process for trying to understand why it's occurred and whether it's unwarranted or perfectly reasonable depending on your case mix? And when it is unwarranted, is there a process that supports the clinical department for working through it? Is there a mechanism of taking things back to hospital management and executive? Going back to Guy's slides, as individuals, do you attend the M&Ms or equivalent meetings? And are your cases presented at M&Ms and the equivalent meetings? So a quick word about mortality, and this is very WA focused. I'm not quite sure how it works in Victoria, but in WA we have a mandatory review of death, and that covers all in-hospital deaths. And the purpose really is to identify both preventable factors as well as opportunities for improvement. And when I say it covers all in-hospital deaths, that includes end-of-life care and patients where the death was expected, because there may be things that you can do to improve the quality of the care. It also includes care that's provided outside the hospital, but where the clinical governance sits with the hospital. So that might be things like hospital in the home or rehab in the home. In this day and age where we've got the demands on hospitals and aged care facilities, it also includes what you might think of as nursing home patients or patients who are in hospital awaiting placement. It includes virtual care and not for resusc patients. Within WA, in addition to the review of death, we've got the WA Audit of Surgical Mortality as well as clinical incident management. And I don't really mind where the death is reviewed, so long as it's done by one and done well. And to that end, we are working to include a mortality module in our clinical incident management system. So there'll be a one-stop shop where all the information is collected, and that will allow people to triangulate between events. In terms of triggers for an M&M, some of our thoughts are things like unplanned or related readmissions within a 28-day period from discharge, any unplanned intervention to rescue a patient, either going to ICU, other higher level of care, going back to theatre and MET escalation. I think each department would have a list of surgical complications they're interested in. We would also recommend things like cases which required open disclosure, consumer complaints, any cases which the clinician wishes to discuss or learn from. And I think also, rather than just always looking at what went wrong, perhaps the cases that went well, where you think there was a learning opportunity provided. This is very similar to what Guy's previously presented, so I'll be really short. I think the key thing here is this a safe space for learning? And how do you find that balance between a robust discussion and that psychological safety and the space for learning rather than blame? Is it multidisciplinary? Again, recognizing that complex care isn't just about the individual surgeon, but the inputs of the rest of the team around them. Is there a systematic structured agenda and documentation of attendance, of outcomes? Are the discussions supported by evidence and data, and do they actually translate to actionable learnings and improvements? And I think one of the observations that I've got is that often the discussions and the learnings are documented and disseminated amongst the people who went, but not necessarily to the wider team, nursing staff, allied health, who may be involved in the care. And then are the governance and reporting pathways in place to actually support the necessary actions and the learning that comes from this? Some of the challenges, I think we're all familiar with how difficult it is as a professional group to do self-regulation. And that comes back to the robustness, evidence base, and a safe place for having that conversation. In a state like WA, sometimes having access to independent or external perspectives is important instead of always doing things the way you've done them previously. Having a multidisciplinary or cross-specialty input, everybody finding the time and the space to participate. The ability to benchmark where we have the data, but often you don't have the data, and then it's difficult to do the comparisons and look for variation in a way that feels fair. What do we do with what we find? I think this is where sometimes we get stuck in terms of making effective recommendations which are actually a useful use of your time, and also when you abut against some of the other hospital processes and you need to change or influence things outside your clinical department. I think culture comes a big deal into this, having the improvement mindset versus the blame and using it as an education opportunity. There have been questions about some of the medical legal interfaces, and there's sometimes a perception that the lack of qualified privilege is a barrier. I would say as a state that hasn't had QP across the public system for over 10 years, and certainly none of our private hospitals have qualified privilege committees. I'm not quite sure if that's a perception more than it is a real barrier. So in terms of closing the loop, and this one's often difficult, particularly if you don't have the infrastructure and the secretariat support, were the meeting minutes distributed? Were the actions, recommendations recorded, delegated? Was it shared with the appropriate groups to make things happen? If it was a clinical incident or a SEC one, was that managed? Were there system factors that were identified and escalated? And certainly sitting where I do in the department, you can sometimes see the same clinician working in different environments having different outcomes, which comes back to me about it's not the individual, it's the system. Were the risk registers updated? And in subsequent meetings, did we follow up on where we've got to with actions and recommendations? Just like to share one slide about culture, because I think this underpins it and it moves it from the blame perspective to the improvement and the patient perspective. I think for a high reliability organization, you have to be prepared to have those conversations, and it's about how do we do this safely. And there is often an onus on the chair on these committees, but it's actually in everybody's responsibility. I also put a slide there about the idea of safety 2 versus safety 1. Safety 1 is what we generally practice across the country, and it's where we focus on where things have gone wrong. But that's actually the minority of episodes of care. So perhaps one of the questions we need to ask to shift that culture is also about how do we replicate things that have gone well. And then my last slide is really just to share some tools, and I'm sure you would have very similar things in your jurisdiction. So in WA, what we've done to support clinicians in M&Ms and in clinical quality improvement is to provide a set of data sets, so that we call them deep dive dashboards, and they're basically been developed based on what clinicians are interested in. So maternity, diabetes, cardiology, renal, etc. And we're currently on the back of a meeting that we had, the tri-state meeting last year, working with some of the surgeons around some surgical outcomes dashboards, which people can then go into, look at their outcomes in their hospital and compare that to other sites in WA. One of the other things we've done is to establish an improvement exchange, which I think of as Squinder, so safety and quality version of Tinder, where it basically is a directory of all the different improvement work that people are doing across the system, and you can go in to look for people who are doing similar work to you. And the last one is a hub that has a variety of different quality improvement tools. And the reason why we put that there is because I think often when we find something wrong or something where we would want to improve, the focus today seems to be on let's do an audit. But an audit doesn't actually fix things. An audit just counts things. So what we want is to give people tools to support the changes they want to make. And that was it from me. Thank you.
Thanks so much, Audrey. That was brilliant. Got one question. With your ministry hat on, I think no one would argue with what you and Guy have said in the first two talks and saying this is the way we should be doing things. But they do take an awful lot of time if we're going to do it properly, and also an awful lot of money. Is that available?
Well, I would say, unfortunately, I don't see any hospital having a bucket of money specifically for this. And I think, ideally, and that's where we come to how else can we provide people with resources to help reduce some of the time in position. And that might be things like electronic tools for doing M&Ms, or and providing some of the data so that it's not all, particularly in WA where we're not electronic, where you don't have to go in through manually pull up notes and things like that. So we are trying to respond in an in-kind support, but actually giving people FTE and the funding for that is a lot more challenging in this day and age.
I thought that might be your answer. In the chat, there's certainly quite a bit of concern about qualified privilege and lawyers getting hold of stuff. Obviously, not many of these people went into the last ANZASM webinar when we had a friendly lawyer saying that she was on our side, but I don't think we necessarily all believe that. I'll introduce Franz, who's a general surgeon, interventional endoscopist at Goulburn Valley Hospital out in Shepparton. And he's going to give us a view on really how it goes in the regions, because I think there is a big regional and metro differentiation.
Thank you for the opportunity to present. So Goulburn Valley Hospital is about 166 kilometers from north of Melbourne. We're one of 6 regional hospitals, and we're the main referral area for Goulburn Valley. We've got a population of about 70,000. We a catchment area of 150,000 people, and we've probably got the most vibrant cultural and linguistically diverse community. I've been told that the community speaks about 38 languages in Shepparton. They predict an expected growth of population about 16% towards the year 2036. So this is this quote by Lieutenant General David Morrison, and I think we're all aware of this one, is the standard that you walk past is the standard you accept. And I think this is probably one of the fundamental principles that we should practice in our surgical M&Ms or audit meetings. Next. Another the previous one. So the format of my talk, we're going to talk about the surgical audit process at GV Health. We're going to talk about our colonoscopy audit, and then subject very close to my heart is the surgical audit and the VASM interaction, as I call it. And the VASM is the Victoria Health and Incident Management System. It's also, you guys might use RiskMan. Next. This is a study presented by Cooper and Yama Surgery that this is an retrospective cohort study that they looked at the proportion of physicians with repeated co-workers concerned that reported by speciality. And as you can see there from this bar graph, that our surgical group is sort of performing quite well. This is quite a large study. They looked over 13,000 patients. It's at 2 academic hospitals in America. They've assessed 202 surgeons over a period longer than 36 months, and they used the NESQIP score. It's a quite interesting study, but for me, the most significant was that the estimated risk of complications, if there's 1 to 3 complications against complaints against a surgeon, the risk of a complication by 18%. If there's 4 or more, the risk is about 31.7%. So clearly from this study is that the way that we interact with our teams ultimately reflect on our patient care. Next. So let's go back to the cold faces, how we do our audits. We audit our total surgical workload. We audit surgical M&Ms. It's protected time. It's a peer review. We see it as a learning opportunity. It's no finger pointing. And also as an opportunity to feedback to our registrars and juniors, and we meet once a month on a regular basis. Next. We must be present. Our surgical audits at least 3 consultants to make it a quorum. We do have SMOs and VMOs. The VMOs, we only report their public work. The audit is prepared by the surgical registrars. We've got GSETs, non-GSETs, and HMOs. Is also attended by the interns, students, and patient safety and quality. Next. So we follow the guidelines from RACS. We determine the scope of practice, so it's our total surgical workload. We benchmark individual surgeons, but also benchmark against quality indicators. We look at all the data from the months prior, the elective emergencies and readmissions, and we interpret mortality, morbidity, and transfers. And I'm going to maybe dissect a little bit out on this as we go along. And then if there's any issues, we obviously have to make changes, and then we have to monitor those changes. Next. We graded our complications according to the Lavindindo classification, and we're all familiar with this. Next. We only discussed at the audit those grade 3s to 4 and 5s. The patients sort of, we give the initials, the UR, the age, the sex. We talk about the admission problem, the diagnosis, the development and the treatment of the complication. Was it avoidable? And what's the effect on the patients? We try to just do 1 slide per complication. Sometimes it might be 2. We add a picture of an X-ray or a CT or the operation itself, and we do it as in a timeline basis. Next. In our plan readmissions, we look at the readmission presentation, look at the procedure. Was that the reason for the readmission? Was it avoidable, and what was the outcome? Next. The transfers, we look at the reason for transfer. Very often it's outside of scope of practice. It might be urology, vascular, neurosurgery. We do ask the question after transfers, could this operation be done at GV Health? And very much to take the burden if from the tertiary centers. We discuss with any delays. And very importantly, we get feedback from the tertiary centre so that we can learn from what they've done to the patient in the tertiary centre. Next. We look at unplanned return to theatres, admission presentation, the procedure, was the post-op complication, subsequent course and outcome. Next. So our unplanned readmission to ICU, the question was, is the post-operative complication, was this patient discharged too early from ICU, was the timing of the transfer appropriate, and was this death, if there's a death, was it expected and was it avoidable? Next. Our mortality, we look at the presentation, was it the representation, is it the post-operative complication, was ICU involved, the date of death, was it a coroner, is there a autopsy requested, and then we classify the deaths, is it expected, the nature of the disease process, unexpected, not reasonably preventable, was it preventable, or was the death due to a recognized complication from surgery? Next. So the challenges in regional for us is our data collection. We get our data from the health information system. Now the data will just tell you the surgeon, what was the operation, the patient, and doesn't tell anything about complications and give us the length of stay. So then the registrars had to work manually through every single case with the chart. Last month, which was 303 cases. So as you can see, it's quite time consuming for them, but we appreciate what they do. And we feed back to them that they're doing a good job. The other challenge, time limitations, we do it once a month, 8 to 9 on a Friday morning. And we managed to do it within that time limit. We've got minimal admin support to do the minutes. Patient safety and quality does not always attend. And our obviously the problems, how do you manage outliers, how do you make change to practice and behavior, as I mentioned in my slide, previous slide. Next. Our gastroscopies and colonoscopy audits, we document all our colonoscopies and gastroscopies on a spreadsheet, Excel spreadsheet, and manually. And that being assessed at the end of the month, and we then analyze this according to our quality indicators for colonoscopies. We look at cecal intubation rate, adenoma detection, SL detection, advanced adenoma detection rate. We also document that, bowel prep, withdrawal time, and follow-up, and make sure that these patients are all followed up properly. The data that we present is individualized, so every surgeon knows their withdrawal times, the adenoma detection rate. We review all the histology and we check that it's been actioned, it's peer-reviewed, and this colonoscopy report is then monthly reported in a de-identified manner to clinical governance meeting. We've employed of late an endoscopy nurse navigator, and she's got lots of tasks, but the important task is that she makes sure that those patients are properly followed up and according to the guidelines. Next. This is how we present our endoscopy data to our clinical governance meeting. It's totally de-identified. It's cropped up a little bit, but it's in the Excel sheet, and it's visible for this meeting, and obviously then visible to exec. Next. So there's a study published in Endoscopy International. This is a single center comparative study where they've looked at the presence of an independent observer, documented colonoscopy quality and metrics, and video recording the colonoscopy resulted in a significant increase in the adenoma detection rate and other quality metrics. So the ortho effect, so it appears if you're being watched that you will perform better, and that's from a colonoscopy perspective. Next. And so lastly, if we look at our audit and our VIMS interaction, that's my thing that I'm quite interested in. This is that feedback from the VIMS to the surgical audit is essential. Now, as we all know, the audits are protected and by the Commonwealth qualified privileges, and it's unlikely that it will generate a VIMS. My personal opinion, if you feel there's concerns, you should actually put in a VIMS in. As we know, patient safety and quality govern the VIMs. And I think if we can connect the VIMs in a surgical audit and surgical M&Ms, there's an opportunity for improvement and an opportunity to close the loop. Next. And I sit a lot on this meetings and the assessments, and the complaints mainly sort of generated by patients and concerned healthcare professionals, family members, and med calls. But all the complaints are investigated, they're graded, they're actioned, and that's in the space of the patient safety and quality. And from these complaints comes recommendations. They most commonly is a process, and the process would be changed. There's ownership to this, and it's regularly assessed if how the progress is made, and then it's audited. And DB Health has developed a decision support tool, which I would like to share with you because it shares important information about serious events. Next. So this is our clinical our decision support tool that we developed sort of in-house here. It's based a little bit on the Queensland one, but we've tweaked it to make it work for us. So when there's a serious incident, we have to do the ISR rating. So is it the level, we assess the level of harm, the duration of harm, and what was the action. So it's a ISR incident severity rating of 1, which will mean death or permanent harm. A 4 will be a near miss or no harm. Then we move on to the next to confirm the validity. So we ask the question, was this a complication of the procedure? Was this part of the consent process? So if any of those green boxes are ticked, of grey boxes are ticked, then we could potentially be a SAPSI, what we call a serious adverse patient safety event. Next. Then we move on to our methodology, our scoring matrix. So then it's a score 0 to 2. So we assess what's the degree of harm. Is there subsequent patient sort of concerned? Is there practice deviations? Is there delays? Is there litigation? Is there political involvement? Is there death? So then we get a score. Next. So then the question is this a sentinel event, like, for example, wrong site surgery or operating on the wrong patients? The one that I find most commonly from the surgical perspective is the lack of recognition of the deteriorating patient. So if any of those boxes are ticked, it's a sentinel event, and you get 10 points. Next. So when we look at the numbers or the numeric values, so if you were a score of 0 to 5, we still ask the questions: is there possible litigation? Do we have all the information? And then what will be the review methodology? And as you can see in the top box there, the second from the book, that this case should be discussed at the M&M. And then 6 to 10, again, this might still be a sentinel event, and the methodology here will be a clinical review or in-depth case review or RCA, and the score above 20 will very often turn out to be a sentinel event. So after we've done this, we will assemble a team, and this team will then investigate, and there's very often an external member like a consumer or an external clinician involved. Next. So this is just our definitions from patient safety, but we still adhere to the Victoria Category 1 sentinel event. So we still evaluate, is this a sentinel event? So, and next. So this is my last slide. So this is how we connect the dots. So we've got our surgical audit, our M&M, which is peer reviewed. So there's a standard agenda item that I've implemented, so that just for 5 minutes, we will discuss the recommendations from patient safety and quality. So the sentinel event, is it from a sentinel event? Is it a SAPSI or RCA or in-depth case review? Then the surgical audit, reports back to clinical governance, and that's sort of tabled at the clinical governance meeting. It's a de-identified report. It will just say the audit has occurred, that it's been attended by these and these so many surgeons who was present, and these cases were discussed. We also tabled our VASM reports at clinical governance, and that clinical governance meeting is attended by patient safety and quality. So they've got membership on the clinical governance, so they then know what we're doing in the surgical audit, and the surgical audit know what patient safety and quality is doing. So that's the way that we close the loop. Next slide. Speak up for patient safety, and thank you for listening.
Thanks so much, Franz. You're doing an awful lot of work there, which is fantastic. Just quick question. Are you using Riskman as your VIMS, or are you using it as a different system?
No, we use VIMS, but it's
Right.
pretty much the same. It's the same principle, really.
Yeah.
So we use VIMS.
Okay.
So the point that I'm making is you have to connect your VIMS with your surgical audit, because I find that the surgeons does not really know what is happening in the assessment of the VIMS and the sentinel event outcomes and the recommendations.
Yeah, I think it's all a collection of the data, isn't it, really? That's sort of the crucial thing. Brilliant. We shall try and move on to Dennis of excellence in a big teaching hospital in Victoria, and he's a fellow urologist and divisional director of surgery at the Northern Health, and he's been there a long time. Also contributes to national training and governance for various committee roles, including the Board of Urology and hospital medical advisory groups. So over to your view on all of this, Dennis.
Excellent. Thank you for the opportunity to present. Really, series of very, very excellent talk. Franz's talk was fantastic, and I think my theme is probably going to be Franz's last comment, which is the connecting of the quality work that's done in the hospital with the M&M work that occurs at our hospital. So, acknowledge the traditional owners of land on which our health service is built on. Now, this, I know it's a very busy slide, but this slide is just one of an example of how the quality team manages when there's actually been a death in the hospital. So Northern Health has an internal algorithm that will categorise a risk of a death and put in a high probability where we think there could be an adverse event, or a low probability. Hopefully you can see the mouse wiggle over there as I go through. This slide indicates that, if you've got a high death, it'll go to the quality team to review. It'll get an expedited review with a head of unit or the divisional director if it's a category 1-2 death. And then there'll be other aspects of investigations that'll be required through that. If it's a low risk, it'll just go through the normal mortality processes of the hospital. The mortality will be reviewed within something like 60 days. There may be some recommendations, etc. from there. All surgical deaths of the Northern go to a surgical sub-mortality committee, which I have the pleasure of chairing. We have a multidisciplinary team review those deaths and also provide a category. We also do a lot of work reviewing any deaths that have occurred in the community for anyone who's been admitted under a surgical unit. Anyone who's been transferred from a surgical unit to palliative care and subsequently passed away, we will track those people as well. And anyone who's been within 48 hours in contact with our virtual ED services. So just to give you a flavour of a mortality incident, I think Franz has summarised really well some of the serious critical, serious other incidences, and we've got a different tool called a SCIRT, which is our structured clinical incident review tool that we use to create our recommendations and investigations. When we look at the traditional M&M process that was in place that, when I first got here and have been exposed to many times during my training through, usually the registrar is presenting a case. It'll be a case specific. They'll give some details. They'll give a narrative of what's occurred. There'll be no real comparisons to any key performance indicators or comparators to other standards. You'll get an anecdotal response from some surgeons giving their experience, and then we just rinse and repeat the same thing. And the issues that I've sort of listed here, I think Guy's summed up beautifully in the beginning of his in his first presentation is, when we've had an outcome, if it's a injury to a common bile duct, how are we comparing as a percentage to sort of international accepted standards? What have we learned? Where is it documented? Where is it stored? What are the corrective actions? Who's going to follow them up? How do we know their action? And interestingly, Fran's pointed this out again too, it's really looking at a very surgical lens, return to theatre, wound complications, the mortality, but things like patient feedback information, that is often missed because you can get some horrendous patient feedback, but the patient's actually had a normal operation and discharged, and we don't get that feedback to improve upon those bits of information. So we have a very surgical lens. So when I look at our outline here, the thing that we're missing is the surgical M&M. We're really siloed here. I think Franz was trying to illustrate closing that loop and bridging that loop. So that was the thing that we really wanted to improve. So really it's a changing of a behavior. And when you're looking at changing of a behavior, you need a prompt, motivation, and ability. And the prompt landed on our desk July 2024, even though we've been fermenting these ideas in the background of how do we improve our M&Ms. It was fantastic that Safe Care Victoria provided this. And this was the really big prompt to actually make some changes. Motivation, I was really motivated to make this change. And I really do have to shout out to one of my colleagues, Associate Professor Russell Hodgson, who really, was another significant driver into driving this change, that motivated to want to change these MDMs. And then we needed the ability and the realization we've got a lot of structures already in place in Northern Health, such as the surgical mortality, sub-mortality meeting, where we look at the adverse events, we look at the mortality, we'll classify, we'll actually have a multidisciplinary team discussion, and we'll come up with a series of questions. And so we've got this ability now to feed that back to the M&M and ask the actual surgeons who are on the ground. The VMOs who are only in for a week, a couple of days a week or a couple of days a month, who are not aware of all the big quality processes that are working in the background about some of these issues. So wanting to change our behaviour. So we started looking at a mortality review or a clinical incident. We would develop the specific answers that we wanted to send to the team. In our M&Ms, we did have to rework some of our timetables around there. So instead of doing the monthly presentations for a unit, just so for the background, our surgical forums are held weekly. They're in the evening, so everyone can attend at sort of an after-hours meeting. We changed the format structure that everyone's going to be presenting every fortnight, which meant the complications when they are presented are relatively, well, thankfully minimal at times. Instead of the monthly one where suddenly you might have 4 or 5, and you then have no real chance to explore in depth those questions. So we changed the format, but more importantly, the format changed to actually have a surgical forum dedicated for the questions and issues that were raised by the surgical submortality team and the quality team to be addressed to the surgeons. And that meant we could then formally invite multidisciplinary team members from ICU, anaesthetics, nursing staff to attend that meeting, and we would structure the M&M around those particular issues. We'd then have our system solutions actions documented, backed up. We'd also monitor some of our critical quality indicators. What's not monitored is not done. And by having these front and centered, we were getting improvement in some of those. And then we've got our closing the loop of communication between our surgical teams and quality teams. So this is an example of our slides from the M&M that we'll bring in. We start with we do our acknowledgement of country, and then we start with this slide outlining that we are a just culture. It's not a blame culture. We are interested in learning. We are seeking to improve the system, and we're free to have open and at times robust discussions. We have a chair who leads this, and that's very important to moderate the discussion, to make sure the discussions remain on the subject and not get deviated off track. When I say about quality indicators, is an example of what we put up. So there's 2 indicators that we're monitoring at the moment. CPF is our signing off methodology. So for CT scans done or histology results, the team's supposed to tick that off. And we have, unfortunately, large numbers unsigned, but since we put this up front, we're seeing this improvement occurring. The other one is our VT risk assessment. During one of our accreditations, we were noted to be a little bit low, and the teams weren't doing the risk assessments when VTE risk assessments when patients were admitted or after 7 days in hospital. So we put this front and centre, and each team does it. And I'm really pleased to report it's made a significant difference into the improvement and the filling in of that risk assessment. In terms of an example of a slide that we would put in, we specifically have the questions in. I must admit, when we first started, one of the lessons learnt was not to have, we've just sort of had the case up and then had a discussion, but things could move across to different areas and could almost verge into the area of criticism. So we have specific issues we wanted to raise. And this is an example of a post-thyroidectomy where there was a neck hematoma and there was swelling noted on the ward, and there was a lot of pre-MEC calls. The neck needed to be opened on the ward, but there was a delay and there was issues with intubation. The poor patient did need intubation and a increased length of stay of about 48 hours. So there was an adverse event. So when we've done our assessment, we knew there was areas of concern that care could have been better. So we had some specific questions to ask and raise. And then and some of the answers that came through here were that when we got down to the nuts and bolts of it, nursing staff were escalating, the junior staff were escalating, but the senior surgical team were not appreciating that there was an issue that was at hand. So I think that the concerns that were raised were that the symptoms and signs weren't appreciated by the surgeons. And the other issue was that was our post-thyroidectomy pack appropriate for someone not trained in surgical procedures? Could anyone use this pack to open a neck? So that led to some corrective actions. So there was some education around the understanding that a airway like this situation is actually like a code blue. So empower the junior team to call a code blue, which would have brought the immediate response. There was an action that the surgical nurses on all the wards where post-thyroidectomy patients are, anaesthetics and ICU go through and review all our post-thyroidectomy packs. And we discovered on all the different wards, the packs were all different. So we were able to standardise the packs. The instructions on how to open a neck was standardised, laminated, and is front and centre of that airway pack. So that was sort of one of the corrective actions that came through it. And I think that sort of sums up how we're now transitioning to a more, I guess, focused direction on the issues that come to hand from both the quality aspects of the hospital and at the unit level of the surgical team. And the key thing, I think as Fran's highlighted, is they do work on different timelines. And so it's making them meet at the same timeline to put it front and centre there. Thank you for listening. Apologies for the technical issues. Happy to take questions.
Thanks very much, Dennis. And I'm sure Safer Care will be delighted at their document
Read by someone?
making some changes. We've gone past 7. There's been a lot of stuff going on in the chat, as I mentioned earlier, particularly about the legal aspects. We can maybe, as we've got the group here, just maybe ask 1 or 2 questions. Should all surgeons use the RACS surgical logbook and have M&M through it with RACS, representing surgeons and interested government, to adopt a legal privilege for those actions and data to be shared legally?
I don't think we should start compelling any particular approach. If there's an advantage in using the RACS logbook for medico-legal protection, which I'm not sure there is, then that might be useful. But I think we don't want to regulate this too much. I think we want to get the concepts and ideas right and let the jurisdictions or the local hospital or the local group of surgeons determine how it's conducted.
Any other thoughts on that? I tend to agree. I think the other problem you've got in Australia, of course, is the different states and the legislation between all the states and territories. So it'd be very difficult for one organisation to give a blanket coverage for what we're doing, which is a point that has been made up in the chat as well, particularly about qualified privilege. Any thoughts about delays between M&Ms when actually events happen? I think the way Dennis has been doing it in the Northern, and to some extent France in GVH as well, suggests that they're picking these things up quite quickly. But I think a lot of this does depend on how you're picking up the data, and is it just sort of the registrars remembering stuff, or are they having to plow through the records as they seem to be doing in Goulburn Valley? Is there a better way we could collect the data and make sure all these things are done contemporaneously?
Well, look at the Northern, Philip. We do get a weekly update of the surgical mortality, so we know the quality team do collect that data. Obviously, traditionally the registrars are keeping track, and I must admit I've not seen a disconnect where a mortality has never been presented at the M&M. I think the acknowledgement is that the M&M presentation of a mortality can happen, but we may go back and readdress that once it's gone through the various committees, because we will identify another issue, particularly an ICU lens will say, hang on, did we consider this point of view? So we, I was going to give an example, I won't, but I think it's acknowledging that even though there is difference in times, you can go back and readdress an issue even though it has been presented. It makes it a little bit easier for the registrar just to put the flash summary up, but with the instruction of these are the specific questions. So their slides only become 2. The summary of the case again, a very brief summary, and then the questions that we want raised answered.
And how are you sure you've picked up all your morbidity? Mortality is a little bit easier because you've got it's a fairly end event.
Morbidity is a little trickier in that sense. There's not, I think when the morbidity involves our SCIRT tool, which is the standard clinical incident review tool that we use, and there are corrective actions that are raised enough that can be fed back at that point in time. So it does, I think it's the overlap, because we do discuss in various other committees. I think Fran sort of highlighted there are different committees that do have their discussions. So we'll have the Surgical Quality Risk Committee that will review a lot of those issues. And a lot of the corrective actions do involve having it discussed at an M&M. So the evidence becomes the M&M as a feedback for closing. So they both feed into each other in terms of tracking in that sense. And so if they haven't discussed it, let's say there is an incident, I can give it a urology example where post-PCNL a retained wire was sheared by the laser during a PCNL, and that was missed, and that wouldn't have been brought up until it became a quality issue that was investigated, and then that was fed back to the unit to review and have their discussions on that issue. So that they didn't know that had happened until the complaint had come through. So it does seem to work when you've got multiple entities in place.
And there's a question here. Do you run M&Ms by surgical specialty? So you have multiple M&Ms going on at the same time, or is it sort of directorate in surgery and anesthesia?
Well, for us in the one forum, it'll rotate fortnightly. So there'll be 2 units presenting, Occasionally we'll have a subspecialty unit presenting. Some of the other services have traditionally had their own service. So the Northern Orthopaedics do that. And so there's the next phase of our iteration of NMs is trying to group them all together and ensure that the processes are similar across. But if we can't group them all together, given the logistics, at least the same issues of the points being raised for discussion can get to those particular specialties.
Question about the Shepparton issues and pointing out that the nursing staff don't appear to be involved. Are some surgeons not keen to have these meetings opened up to whole teams? Anyone can answer that. Franz, what do you think?
So from the Shepparton perspective, I mean, initially I had my hands full when I started here 2.5 years ago, just to get patient safety and quality in the room. But I agree. I mean, where I worked previously, we had coding there, we had nursing staff there. So that gives that sort of multidisciplinary sort of flavor to it. And good point. I will probably take it to my team and ask them if they will be happy to have nursing involved. I think it would be great.
Okay. I really would like to thank all the speakers for some wonderful presentations. I would also like to thank everyone else for coming along to the meeting and to contributing to the Q&A, because there's been some really interesting points in that. And I would finally like to thank the VASM team for pulling it all together for me, and look forward to the next one. So